more than 2 weeks sadness. Important chapter. Study it very well. Dermatology, ENT, elderly care we finished, endocrinology, environmental, gastroenterology, hematology, infectious disease, maxillofacial and dental, and today mental health, inshallah. So we will discuss clinical presentations, aggressive or disturbed behavior, anxiety, panic, physical symptoms unexplained by organic disease, self-harm, refusal of treatment, conditions related to this presentation like alcohol and substance misuse, depression, eating disorders, personality disorders, acute psychosis including bipolar, schizophrenia, somatic symptom disorder, stress disorder, suicide. Guys, can you hear me clearly, please?
Yes.
Okay. So regarding aggressive or disturbed behavior, what to do with the patient? So you will start escalation. So verbal, you talk with them first. After that, you escalate your actions until you reach IM or IV. Anxiety, panic. So the patient has panic symptoms. So how to understand that from the scenario? We will discuss that. Physical symptoms unexplained by organic disease. The patient is complaining from physical symptoms and all lab are normal, all examination are normal. So self-harm and suicide. So the same. So you will use score, modified that person score. You have to be familiar with that. They can ask you by different ways. Refusal of treatment. So you have to be familiar with consent, how to take consent, and how to assess capacity, and also if the patient lacks capacity, what to do. If the patient have capacity, so what to do. Alcohol and substance misuse. So alcohol here maybe binge drinking or maybe alcohol dependent. Substance abuse, any substance, whatever, marijuana, ecstasy, or illicit drugs. So here, most of them, you have to ask the patient questions regarding alcohol, if he's using alcohol, or ask questions regarding substance abuse, if it's a substance abuse. So asking questions, it means examination. Asking questions, it means screening. So you are doing screening for his alcohol use or substance misuse. Okay. So according to these questions, according to this screening, according to this examination, you will understand the status of the patient and you will do intervention. Intervention here, it means you will talk with the patient, you will explain to him the risk and the benefits of alcohol, the risk and the benefits of substance abuse, and you will persuade him to stop drinking alcohol if it's alcohol, or to stop using illicit drugs if it's drugs, or at least decrease the amount. Okay, and persuade him to counsel alcohol and drug specialist. So this is how to deal with these situations. Depression, you have to be familiar with the definition of depression. As we said, more than 2 weeks sadness. So you will find at least 4 or 5 symptoms of depression for at least 2 weeks. We will talk about this conditions in detail. Eating disorder, so the patient has bulimia nervosa. We will discuss that. Personality disorder, you have to be familiar with the symptoms in the scenario. So we will diagnose he has personality disorder. Acute psychosis, so the patient has symptoms of psychosis, as we said, maybe thought disorders or hallucination or delusion. Okay, so thought disorder, he feels someone or something interrupting his ideas. Someone is putting ideas in his mind. Someone is removing ideas or stealing ideas from his mind or interrupting ideas in his mind or spy his ideas, broadcasting his ideas. Okay. So this is called thought disorder. Or maybe hallucination. The patient can see, hear, smell, touch something which is not there. So it's called hallucination. And here, psychosis, the most likely will be auditory hallucination in schizophrenia. Okay, so bipolar disorder, sometimes the patient has mania, sometimes the patient has depression. So bipolar disorder. So here, acute psychosis, including bipolar or schizophrenia. Somatic symptom disorder, we will discuss the features of it and how to diagnose from the scenario. Stress disorders and suicide. So again, suicide here connected with self-harm. So aggressive or disturbed behavior, mental health presentation number one, what to do if the patient comes to you and aggressive. So aggressive here, maybe the patient has something organic like hypoglycemia. So don't go directly to restrain the patient and give him medicine like lorazepam or haloperidol. No. So first of all, you have to be familiar with the causes of aggression or the causes of any unwell patient. So organic causes like hypoglycemia, stroke, drug, alcohol intoxication, or withdrawal. Also, you can consider other organic causes, many causes like head injury, like sepsis, like shock. Okay, so you have many causes for organic causes. So any cause for unwell patient. Okay, so it will be better for that. Okay, so psychogenic causes, maybe the patient has acute psychosis, including schizophrenia, bipolar disorder. So what is the first action? To do bedside test. You are talking with the patient first and check his blood sugar, bedside test. ECG, maybe he has arrhythmia, that's why he's aggressive. Maybe low cardiac output, that's why. ABG, maybe he has hypoxia, and because of hypoxia, he's aggressive, agitated. Pulse oximeter, chest X-ray, maybe he has any carcinoma or Parkinson tumor, that's why he has hypoxia, or maybe he has superior vena cava syndrome. Urine dipstick, so maybe the patient has UTI, especially in old age. Also, urine beta HCG. So here the patient may be pregnant, female. So you have to check that. Management, so psychological and behavioral de-escalation. So first of all, diffuse or talk down disruptive behaviors and to prevent violence. So first, verbal, talk to the patient, de-escalation. So avoiding confrontation, don't argue with the patient, don't shout at him, So avoiding confrontation, redirecting the patient towards a calmer personal space, observing for signs and symptoms of anger and agitation, approaching the patient in a calm, controlled manner, giving the patient choices, maintaining patient dignity. So give him choices. Would you like to blah, blah, blah? So he can choose. And maintaining patient dignity. So, for example, if you want to restrain him, don't put him on his abdomen. No. So keep his dignity. Lorazepam, haloperidol, combined bromazepam. When to give the patient lorazepam, when to give haloperidol with bromazepam, we will discuss that. So if you give lorazepam or you give haloperidol and bromazepam, so when to repeat, it will be after 15 to 30 minutes. Regarding haloperidol, it has side effects, acute dystonic reaction. So they can give you this image, or if you search in Google, you will find different images for acute dystonic reaction. Be familiar with image of acute dystonic reaction and how to treat this side effect. So you can give procyclidine 5 milligram or benzotropine 2 milligram IV. So both of them can be a question. So this one, question, question, question. Okay. Here, the basal ganglia in the brain, this one, the red color. Okay. Any red color, it's basal ganglia. Okay. And the related structures, the blue color. It can make balance between dopamine and acetylcholine. The normal person is not agitated, not hypoactive, not hyperactive because of basal ganglia. So if acetylcholine excess, what happened? Acute dystonic reaction. So you have to reverse acetylcholine. You have to give antidote for acetylcholine to prevent or to treat acute dystonic reaction. So you will give anticholinergics like benzotropine, diphenhydramine. Okay. So the following factors increasing the risk of violence. So if you find the patient is male, so high risk for aggression. Okay. Young age is than 40, so high risk for disturbed behavior. Poor level of self-care. Prior violent episodes. He has history, past history in the record, his file. Multiple attendance to hospital. Alcohol intoxication. Organic psychosis. So all these are high risk factors. When examining a disturbed or violent patient, your own safety should be the primary concern. So take care. Your own safety should be the primary concern. Your own safety, you and your team. Ideally, the room should have the following features. How to keep safety, internal inspection window that allows staff to make regular checks on you and the patient. So they can see you, other staff, internal inspection window that allows staff to make regular checks on you and the patient. Unembedded exit, ideally with outward opening door that is easy to exit zone. A room close to well-staffed areas. It is important to avoid examining patients in isolated areas. Why? Increase the risk of harm to the assessor. The room should be comfortable, but it is unnecessary to have abundant furnishing. In fact, Excess furniture, unnecessary equipment can be used as a weapon. So the room should be empty. Only the most important equipment, like bed, like anything necessary for the patient, but not all furniture. Examination code is not required and again could be used as a potential weapon. A secure locking mechanism is not needed, and the room should be easily accessible to other staff during the assessment. The room should not be used as detainment area for the patient, and they should not be locked inside. This is how to keep safety for you and your team. So already the patient is not responding to verbal, is not responding to oral tablet, is not responding to manual restraint, is not responding to mechanical restraint. So you have to give lorazepam or haloperidol combined promethazine. We discussed regarding de-escalation before in previous chapters. So we will go directly for IMIV. When to use lorazepam, when to use haloperidol combined with promethazine. Don't choose haloperidol only. So should be haloperidol and promethazine. It's one option. Otherwise, lorazepam. So the first line is lorazepam. If there is contraindication, you will use haloperidol combined promethazine. The choice of drug depends on several factors. So possible intoxication, previously documented responses to this medication. If the patient took before, like 3 months ago, given lorazepam and he is not responding, so no need to give lorazepam now. You can go directly for haloperidol. So previously documented responses to these medications. Interactions with other medications and the presence of pre-existing physical health problems or pregnancy. Insufficient information to guide the choice of medication for rapid tranquilization. So if you don't have any information regarding this patient or the patient presented for the first time, so you can go for IM lorazepam. So how to understand that? Check the scenario. If you don't have any information in the scenario, so what you will choose, guys?
Lorazepam.
IM lorazepam. You don't have sufficient information in the scenario, and they give you options. You will choose IM lorazepam. The surface user has not taken antipsychotic medication before, so you will use IM lorazepam. Evidence of cardiovascular disease. So they give you scenario for patient agitated, and they give you ECG, and you find it's a prolonged QT. Okay, so you will use what, guys?
Lorazepam.
Yeah. So IM haloperidol combined with IM promethazine should be avoided here. You will use IM lorazepam in this case. So maybe they will not mention ECG, but they will mention in the scenario ECG done and shows prolonged QT interval. It means you will use IM lorazepam. Now you choose the option for IM lorazepam and you find partial response to IM lorazepam. What you will do next action? So further dose should be considered. No response to IM lorazepam at all. So you will use IM haloperidol combined with IM promethazine. So if you find partial response to IM lorazepam, give another dose. After how long, guys? Further dose?
15 to 30 minutes.
Into 30 minutes.
15 minutes.
Yeah, 15 to 30 minutes. If the patient is not responding at all, so next action or option you can choose IM haloperidol combined with IM promethazine. If you find partial response to IM haloperidol combined with IM bromazine, again, further dose should be considered. If you find no response to IM haloperidol with IM bromazine, you will give IM lorazepam, should be considered if not used. Okay, so any medicine you will give, you find a partial response, give another dose of the same medicine. If you don't find a response at all, go for the next medicine. Okay, if IM lorazepam has already been used, so now you give lorazepam, no response, and you give haloperidol, no response. So no response for 2 treatment. What you will do, guys? Urgent team meeting to carry out a review and or a second opinion. So you can choose this option. After rapid tranquilization, the patient should be monitored for side effects. So if you give the patient medicine, whatever lorazepam or haloperidol, so observe, maybe you will get side effect, special haloperidol. What is the side effect for haloperidol, guys?
Acute dystonic
reaction. Acute dystonic reaction. And their observation checked regularly. So you will check heart rate, blood pressure, RRT, level of hydration, level of consciousness, at least hourly, until there are no further concern about their physical health status. So you will check vital signs hourly. Mental health presentation number 2, anxiety, panic. So how to diagnose from the scenario? Here, of course, the patient will get hyperventilation because of anxiety. So you can expect the ABG will be respiratory alkalosis. So again, remember this slide you will find in most chapters. Okay. What is the difference between anxiety and the panic attack or panic disorder? Generalized anxiety disorder, panic disorder. The main difference between generalized anxiety disorder and the panic disorder is that generalized anxiety disorder symptom mainly anxiety based. So you will find symptoms of anxiety mainly in the scenario, while the main characteristic of panic disorder is panic attack. So what are the features here? What are the features here? In generalized anxiety disorder, muscle tension, aches, headache, fatigue, trembling, twitching. Remember that because maybe you'll find in the scenario, so you will diagnose generalized anxiety disorder. Irritability, difficult swallowing, and the feeling of a lump in the throat. Okay, so you can find that in the scenario. So what is the diagnosis? Generalized anxiety disorder. The anxiety of panic disorder is mainly centered around the panic attack. So panic attack, short, intense episode associated with overwhelming feeling of dread and fear, which may or may not be related to specific situation. So if you find the patient is fearing of something or scared, so it's going with panic attack. So you'll find dizziness, sweating, chills, nausea, trembling, shaking, abdominal cramps, throat tightness, shortness of breath, numbness in extremities, rapid heartbeat, palpitation, chest pain. So if you find these symptoms or these features, it's a panic attack. Also, maybe the patient is using marijuana, cannabis. So the clinical feature of cannabis use, exaggeration of pre-existing mood. The patient has euphoria, maybe depression or anxiety, distortion of time and space, increased enjoyment of aesthetic experience, visual hallucination, dry mouth, coughing and irritation of respiratory tract, increased appetite, decreased body temperature, redness eyes, irritation of respiratory tract. And what else, guys, with marijuana, if you remember from other chapters?
Hyperemesis.
Hyperemesis. Okay, so the patient has nausea vomiting, recurrent nausea vomiting, recurrent attendance to ER, and all lab are normal. Okay. So presentation number 3, physical symptoms unexplained by organic disease. Means the patient has symptoms. If you will examine the patient, you will find all examination normal and all lab are normal. Meadow syndrome was formerly known as Munchausen syndrome by proxy. So this is the first name and this is the new name. In this syndrome, the caregiver fabricates the appearance of health problem in another person. Typically, their child. So the mother bring her child, she's complaining the child has blah, 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 blah. And you examine the patient, he doesn't have any problem. So she's inventing disease. Okay. This can include injuring the child. She can injure her child to give the patient disease or her child disease, or altering their test results and then presenting the child as being sick or injured. So she can give you fake blood results to her child. So you will give him treatment. Okay. But if you examine the patient, he's well. Okay. So take care of this situation. Features that would support a diagnosis of Meadow syndrome. How to understand this diagnosis? Reported symptoms or signs only appear or reappear when parent or guardian present. So you will find these symptoms or signs only when the parent is present. Reported symptoms only observed by parent or guardian. Symptoms don't respond to treatment or medication. For example, she would say the patient, her child is vomiting. You give medicine for vomiting, the patient return again. First examination, the patient is normal. Second examination after 2 days, the patient is normal. He's very well, vital signs normal, and everything is normal. And she is coming back complaining from the same symptoms. History of illness, which seems unlikely. For example, she will say he has large amount of blood loss without drop in hemoglobin or change in physiological data. So her child has massive hematemesis and you examine the patient normal. His full blood count normal. Parent or guardian seeking multiple clinical opinions. So you find the same patient and the mother open consultation for you, for your colleague, other colleague. So she's seeking multiple consultations. Persistent disagreement. She is not persuaded by the management. Persistent disagreement with a clinical opinion by parent or guardian. Significant compromise of a child's normal activity by frequent presentation. So, school absenteeism, child using aids to daily living that are apparently not necessary. So, for example, she will attend the hospital, she will ask for a wheelchair for her child and no need for a wheelchair. Okay. Or maybe she's giving him hearing aid or glasses is not unnecessary for him. His vision is okay, his hearing is okay. The parent having suffered negative event or trauma during their childhood. So what is the reason behind that? Because of this issue. The parent having suffered negative event or trauma during their childhood is the principal recognized risk factor for this condition. For example, death of parent or having been a victim themselves of child abuse or not. So what happened to the mother in her childhood? Maybe She has death of parent. Maybe she has abuse or neglect in her childhood. Physical symptoms unexplained by organic disease. Meadow syndrome should not be confused with Munchausen syndrome, where the individual pretend to be ill or deliberately produce symptoms of illness themselves. Okay. Hypochondriasis, excessively unduly worried about having serious. So you have to be familiar with these terms because maybe you will find in the scenario, in the options, so you will understand what is that, what is that, what is that. So hypochondriasis, excessively and unduly worried about having serious. So how can I help you? I am worried, I have cancer. She's well, she's very well. Vital signs normal. She doesn't have any symptoms, but she's worried of serious illness. So it's called hypochondriasis. Somatic symptom disorder. So somatization disorder. Extreme focus on physical symptoms, pain or fatigue, significant emotional distress and the problems function. Cancer syndrome, rare dissociative disorder characterized by nonsensical or wrong answer to questions, and the other dissociative symptoms such as amnesia, conversion disorder, often with visual pseudo hallucination and a decreased state of consciousness. So you will ask the patient, do you have blah blah? Yeah. Do you have blah blah blah? Yeah. So the patient is giving you wrong answers. Okay. So she will be sick. So this is called cancer syndrome. Mental health presentation number 4, self-harm. Again, self-harm and suicide, you have to use modified sad person score. So risk factor for self-harm. How to understand this patient will harm herself or harm other people. So sex, male, 1 point. Age, self-harm rates peak in 16 to 24 years and 25 to 34 years old men. Suicide rates are highest in both men and women aged 45 up to 49 years. Also, socioeconomic disadvantage, it's a risk factor for self-harm. Social isolation, whatever the patient, single, widowed, or divorced. Stressful life events, for example, relationship difficulties, previous experience in the armed forces, child maltreatment, or domestic violence. Bereavement by suicide, mental health problems such as depression, psychosis, schizophrenia, bipolar disorder, post-traumatic stress disorder, or personality disorder. All these are risk factors for self-harm. Chronic physical health problems, alcohol and or drug misuse, involvement with the criminal justice system. So if you find any of them and they ask you which of the following is considered the risk factors for self-harm, so you can choose. Be familiar with all. So modified sad person score or scale. So sad person, sad S for sex, male 1 point, age less than 19 or more than 45 1 point. The most important for you, and they can ask you directly, which of the following can score 2? So DROS. If you find D, choose. If you find R, choose. If you find O, choose. If you find S, choose. So D for depression or hopelessness. The patient maybe is not depressed, but he feel hopelessness. So it's a 2. Rational thinking loss. What does it mean? So the patient has psychosis or organic illness. It's called rational thinking loss. It's 2 points. So if the patient has, for example, organic illness, psychosis here, as we said, thought disorder or hallucination. So if you find in the scenario the patient mention interrupting ideas or stealing or putting ideas, so it's a thought disorder. It means a two. Or maybe he has hallucination, whatever he can see, smell, hear, or something touching him or someone touching him. So this is called psychosis. It means 2 point, rational thinking. Organize the plan. So the patient, whatever he tried to harm himself, or maybe he tried to suicide. So organized here, maybe he closed the door, he went to the pharmacy to buy tablets. He was thinking about that like 1 week. He deactivated all social media. So it's organized. Instead of future attempt, he's planning to do that again. So all are two. You have also 1 point, previous suicidal attempt or psychiatric care, excessive alcohol or drug use, 1 point, single widowed or divorced, 1 point. So be familiar with that. So 0 to 5 may be safe to discharge depending upon circumstance. So you will discharge this patient or you will do psychiatric assessment, guys, consultation.
Discharge, probably.
You will discharge or you will do psychiatric assessment.
Psychiatric assessment. Depending on circumstances.
It's better to do psychiatric assessment. Here may be safe to discharge. It means if you want to discharge, but it's better to do psychiatric assessment. The patient, for example, is depressed, score 2, okay? And he has sadness for more than 2 weeks. He is male and his age is than 19. So it's better to do psychiatric consultation, okay? Yes, may be safe to discharge, no worries, but better to do consultation. 6 to 8 probably requires psychiatric consultation. It means don't discharge. So this one may be safe to discharge, but this one, say 6 to 8, don't discharge, probably requires psychiatric consultation. More than 8 require hospital admission, okay? So what if the patient 6 to 8 and he want to go home? What you will do, guys?
You have to place the mental intact.
Mental capacity.
So what you will do with him?
Assess the capacity.
Okay, assess mental capacity. The patient lacks capacity. What you will do?
Put a mental health act.
Okay. So
Rest.
okay. So if the patient 6 to 8 or more than 8, and you find he has organized plan and he has a stated future attempt, what you will do? And he has capacity. You explain to him, Mr. Sami, you have high risk for yourself to do harm for yourself or for other people. And for your safety, we need to consult psychiatric team or mental health team. And for your safety and for safety of other people, you will be admitted here in the hospital. You are taking consent from him for voluntary admission. And he refused. He said no. You check his capacity, 4 points. He understands the information. He can retain the information. he can weigh the information, and he can communicate the decision. Communicate by talking. He said, no, I want to go home. So what you will do, guys?
The first step is to involve the relatives or someone who knows him, who can convince him. This is the first step.
Okay, so first of all, ask him, can you tell me why you want to go home? So explore the reason. Maybe he want to go home and come back. Maybe he will check his children and come back. Okay, can you tell me why you want to go home? So explore the reason behind that, number one. Okay, number two, so if he said no, I don't want admission. He said clearly, I don't want that. So he refused the management. Okay. So the next action, would you like to call any of your friends or relatives to support you in your decision? He refused. No, I don't want. So what is the next action, guys? He has capacity and he has a score 6 to 8 or more than 8.
This one need admission, social worker and police.
You mean
Because it,
you mean determined?
Section.
You mean section?
yeah, because it's
because active plan to harm himself. Is a danger to himself and to the public.
Okay, so this logic was 6 to 8 or more than 8, right? What about if the patient 0 to 5, it may be safe to discharge, right? But here he has organized the plan or he has a stated future attempt. You ask him, if you will go home, will you try to kill yourself? He said yes. So 0 to 5 and he has capacity. What you will do, guys?
The same, because he is a threat to danger to himself. He states future attempt.
Excellent. So you have to detain him also. Section. Why? Even he's safe to be discharged for 0 to 5, but for his best interest and the public interest, it's not safe. So maybe 0 to 5, but it's not safe. That's why maybe, they said here, maybe, take care. They did not say safe to discharge. Maybe. Maybe here, it means he has no best interest and he has no public interest. Okay? But if he has best interest and public interest, it means he has no organized plan, 0 to 5, but without any self-harm. Okay? So maybe 0 to 5, like his sex, his age, depression, excessive alcohol, but without previous self-harm, without organized plan, without a stated future attempt. So discharge, no worries. Okay, but of course after assessing capacity. So assessing capacity here, you will ask him questions of what, guys? It will help you in OSCE exam also.
Yes, can you repeat the question?
Yeah, how to assess capacity?
Capacity to make sure that he understands. I will tell him the diagnosis and all, make sure that he understands it, he retains and he communicates his decision.
Yes, what you will do before that?
Mental state examination.
Excellent. Mini mental state exam first. So you will check his cognition. Maybe he's not oriented. Okay. So first of all, can you tell me what is the day-to-day? What is the city? Do you remember who am I? Even briefly, if you will ask him 3 questions, more than enough. If he said yes, we are in the hospital. Today is Saturday. We are in the morning, and you are Dr. Hani. So he has cognition. He's oriented. So oriented means 3 important points. orientation to place, to time, to person. Okay. After that, you can jump to assessing capacity. If the patient is not oriented, is it logic to go for assessing capacity, guys? 4 points?
No, no,
It's
no,
not
no
logic.
need.
It's not logic, okay? This is what I mean. Okay. So again, if you find the patient 0 to 5, maybe don't say it's safe to discharge. No, maybe means check if the patient has self-harm to himself or others, whatever, past, current, future. It will be different. Why? Because it means for his best interest, you have to detain him. For public interest, you have to detain him, whatever the score. Consent ensure any person who has self-harm gives informed consent for management. If a person refuses management that is perceived to be in their best interest, assess their mental capacity. If a person refuses treatment, determine the reason. Why? Provide information about the potential consequences of not receiving hospital treatment and assessment. If a person is judged to have diminished capacity and or presence of significant mental health disorder, refer for urgent mental health assessment. So he went to refer for mental health assessment if the patient diminished capacity or significant mental health disorder. Like what? The patient has schizophrenia. The patient has mania. Okay. So those people, you can do urgent mental health assessment or hospital admission, depending on clinical judgment. Healthcare professionals have a duty to act in the person's best interest. This may include taking the person to hospital for further assessment and the treatment against their wishes. If there is uncertainty about whether a person has capacity to make informed decision, seek advice from psychiatrist who has experience in assessing capacity. If the person is judged to have capacity and doesn't have signs of mental disorder, by law, they have the right to refuse hospital admission and or to refuse life-saving treatment. So when to accept or respect his decision if the patient has capacity and doesn't have signs of mental disorder. Take all steps to persuade them to attend the hospital or have treatment. If the person allowed, involve family and the carer. Seek advice from senior staff, clearly document their wishes, and they are against medical advice. Consent means propose the action and the mental capacity. It will give you decision. So maybe explicit or express consent, maybe implied consent. So expressive or express consent actively agrees verbally or in writing. Maybe the patient will say, okay, or maybe he will write if he cannot communicate verbally. Implied, so signaled by the behavior of a person. So, can you give me your arm? I will insert the cannula. He did not talk, he did not write, but he gave you, he extends his arm. So it's implied consent. Mental Capacity Act 2005, designed to empower and protect those who lack mental capacity. So you feel the patient, he doesn't have capacity, it doesn't mean he doesn't have. So you have to presume he has capacity. Support him to make his own decision. Don't assume that he lacks capacity if his decision seems unwise. So if his decision different than your decision or different than you expected, so it doesn't mean he lacks capacity. Okay. You want to go home, it doesn't mean he lacks capacity. Always act in his best interest. It chooses the least restrictive treatment and care option. So 5 principles of consent, of assessing capacity.
Honey,
Yes.
I'm sorry, the use of restrict. I mean the last point.
Yeah.
What does it mean?
What do you
Choose
think?
the least restrictive
What do you think,
treatment
guys?
and
Least restrictive treatment. What does it mean?
We have to make sure that we don't.
Manual and physical restraint should be least.
Again?
Physical restraint.
So whatever measure is taken should be the least damaging to the patient. It must be justifiable or appropriate as much as
Yes.
possible.
Least restrictive treatment. So the list for the patient. So the list and better option for the patient. So mental capacity here, understanding relevant information. So you have to give him information first. You cannot assess the capacity without information. So for example, you took overdose of paracetamol, and this can affect your organs, can cause liver damage. If you take paracetamol antidote, which is called N-acetylcysteine, so it will protect your organs, especially the liver, and it will protect your life. This is the information. After that, check if you understand or not. Can you repeat that for me to be sure that you understand? I correctly explained to you. So he will tell you, retain. And if he give you decision, whatever, by writing, by verbal, so he can communicate the decision. So refusal of treatment, presentation number 5, may be voluntary or compulsory admission. So the patient you want to admit for psychiatric assessment or for treatment. So you have to persuade him. Maybe he will say, okay, so it's a voluntary admission. Maybe he will refuse. So you have to detain him. Means compulsory admission. So voluntary, every attempt should be made to persuade them to go voluntary. Compulsory, if admission is necessary, but the person declined. So compulsory admission here under sections 2, 3, 4, 136 Mental Health Act. Okay. So when to do compulsory admission, the patient have mental disorder of nature and the degrees that warrants assessment or treatment in hospital. Also need to be admitted in the interest of their own health or safety or for protection of other people, as we said in the start. So if you feel the patient has previous self-harm, current self-harm, or future self-harm, so you have to admit for the interest of their own health because he will harm himself, or for protection of other people if he's intending to harm other people. So we said section 2, 3, 4, 5, and 136. Section 2, compulsory admission for up to 28 days for assessment. Okay, so if they said the patient needs assessment for 28 days under section 2, if they said the patient needs compulsory admission up to 6 months for treatment, so section 3. Section 2 and 3 require application from approved mental health professional or the person nearest relative. So you will take approval from mental health professional or the person nearest relative, written recommendation from 2 doctors or psychiatrist and GP. So these are the requirements. Section 4, compulsory admission for up to 72 hours where undesirable delay in section 2. So if the patient already your section for 28 days for assessment, but you need to admit him and there is delay, so you can go for section 4. It will give you rapid section for up to 72 hours. Section 5, temporary strain while awaiting assessment by psychiatrist for admitted patients. Patient in emergency department is not an inpatient, so cannot be detained under this section. Section 5, you have section 5.2 and section 5.4. 5.2, doctor holding power and the duration 72 hours. So this one for doctor, 5.2. This one for nurse, 5.4. Registered mental health nurse holding power, duration 6 hours. Section 136, this one for police, to take people from public place to a place of safety and enable examination by a registered medical practitioner and interview by approved mental health professional. The person GP were known may be informed. Who can consent for a child under 16? So we are talking about consent and the refusal of treatment. So adult with parental responsibility. So the patient is 16 years or 15 years and he has appendicitis. They can ask you in the scenario, who can give him consent? So should be adult with parental responsibility. How to understand the father or the mother, they have parental responsibility. So the mother, she has automatic parental responsibility. No need to check her papers, okay? The mother already, she has parental responsibility. So you have to check the father. The father to get parental responsibility, 2 factors, should be married to mother at time of birth. Number 2, listed on birth certificate, any one of them. It's not mandatory for both, any one of them. So married to mother at time of birth, listed on birth certificate. What about age group of individuals are presumed to have capacity? All individuals more than 60 years, so presume that they have capacity. 3 situations in which individual can consent on behalf of another person. So in a children 0 to 15, by adult with parental responsibility, as we said, less than 16. So the first situation, if the father has parental responsibility, he can consent on behalf of children less than 16. What about children 16 up to 17? If they lack capacity, so adult with parental responsibility. An adult who lacks capacity, so lasting power of attorney. You have 3 situations. So factors need to be true in order for consent to be considered. So the dad who consent for his children less than 16, how to understand it's valid? So should be voluntary, should be informed, and that should have capacity also. So you will assess his capacity. He has cognition, is oriented to time, place, and the person. He can understand, retain, weigh the information, and he can communicate the decision. We have lasting power of attorney and advanced decision. So lasting power of attorney, as we said, may be the patient adult, lacks capacity. So this patient, he can ask another person, okay, to consent for him. But of course, he should consent, he should give him lasting power of attorney when he was competent, in case he lacks capacity, okay? So someone else to make certain decision on their behalf when they lack capacity to do so. This is the meaning of lasting power of attorney. What is the meaning of advanced directive? So person can refuse treatment in a predefined future situation. So here, the same person, the same person asks someone else to give consent when he lacks capacity. Here is the opposite. He will sign consent. He will not receive treatment when he lacks capacity. Okay. So what are the criteria indicates that lasting power of attorney is valid? Lasting power of attorney documents must be registered with the Office of the Public Guardian, should be written, signed, when can be a question. Adult age 18 or more. It can be a question. Which of the following indicate lasting power of attorney is valid? Situations indicates that lasting power of attorney is not valid. It's the opposite. So when the donor has the capacity to consent. So here, this patient, he made lasting power of attorney for another person. And this patient now, he has capacity. So this one, not valid. When the donor has made advanced decision to refuse treatment. So he has advanced decision after lasting power of attorney. So the last one is valid. So if the patient has lasting power of attorney, after that he has advanced decision. Which one is valid, guys?
The advance directive supersedes.
Yes. If the patient has advanced decision, after that he make lasting power of attorney. Which one is valid?
Define
LPA.
LPA. Okay. So the last one is the valid. Okay. So when the decision relates to life-sustaining treatment, and this has not been expressly authorized. When the donor is detained under Mental Health Act. So if you detain the donor, the patient, and he has lasting power of attorney for anyone else, so it's not valid. What about advanced directive? As we said, person can refuse treatment in a predefined future situation. So the patient will sign document now. He will say, I will not receive treatment in the future if I have cardiac arrest. So you will not do CPR for this patient because he has document last month or last 3 months for not receiving treatment. So how to check it's valid or not? So if you find adult age 18 or more, it's valid. If you find the patient was competent, it means when he signed this document 3 months ago, he was competent and fully informed when he was doing advanced directive document. Written, signed, and witnessed. Advanced directive is applicable to the current circumstance. So he said, he signed the document and he said, I will not receive treatment for cardiac arrest. But today he was presented with trauma and he has multiple injuries. You will do resuscitation, guys, or you will not do?
Will do.
Yes, you will resuscitate until the point of cardiac arrest.
Yes, you will resuscitate until cardiac arrest because his advanced directive, he said, or he documented in his document, he will not receive CPR. So it's specific only to CPR. You will resuscitate him, but in case he will get cardiac arrest, he will not do CPR. If he signed advanced directive 3 months ago, he said, I will not receive resuscitation in case I have trauma. And now he has cardiac arrest. You will do CPR or not?
Yes, we'll do CPR.
Yeah, okay. So the patient has advanced directive. Check first, he's adult, 18 or more or not. He was competent and fully informed when he was doing AD or not. Check this document is written, signed, witnessed. Check if this applicable to the current circumstance. So what if not valid? It means the patient 16 years. So it's not valid. the patient, the document, it's not written or not signed or no witness. Okay, so any witness should be two persons, like any document in our life. So not valid. What you will do? Check if the patient has valid LPA. Maybe he has a lasting power of attorney to other person. So first of all, check if he has LPA. If not, manage the patient in his best interest and least restrictive manner. Okay, so you can treat him in best interest. It means if he needs resuscitation, do resuscitation. If he needs intubation, do intubation, and the least restrictive manner. So it's clear now. Condition number one, mental health. Condition number one, alcohol and substance misuse, binge drinking, and harmful drinking. So binge drinking here, the patient first time he will drink now, and he drank more than enough, and it's not related to alcohol dependence. Okay, so pattern of alcohol consumption that brings the blood alcohol concentration level to 0.08%, means 5 or more drinks on a single occasion for men, or 4 or women within 2 hours. Okay, so harmful alcohol, pattern of alcohol consumption that cause harmful effects on physical, mental, physiological health. So any alcohol, any amount which cause physical, mental, psychological effects, so it's called harmful alcohol. So what is the safe limit for male and female? Maximum 14 units per week. Okay, and the maximum how many units per day, guys?
6 units.
3 units
3 units per
per day. Okay, so they can ask you what is the advice rather than stop. So if you will ask the patient to stop, it's not advice. Okay, so this is called brief intervention. So first advice is spread the recommended amount of alcohol consumed over 3 days or more, with 3 days each week. It's important here, 3 days. Why? Maybe you will advise the patient to drink 3 units per day. He will drink Saturday, Sunday, Monday. It's harmful. But if you will drink Saturday and Monday and Wednesday or Thursday, so it's safe. So 3 days in between. Limiting the amount of alcohol on any one occasion. So this one for dependent, number one, and this one number two for to prevent binge drinking. So limiting the amount of alcohol on any one occasion. So if the patient has party, so you have to give him a limit in this stage. So regarding alcohol and substance misuse, so this patient, you will find raised mean corpuscular volume in the scenario, raised GGT in the scenario. Okay. And what about the EPG, guys? Alcohol?
High anionic gap.
Hagma. Okay, metabolic acidosis. Okay, so what are the questions to ask the patient? We are talking about alcohol and substance misuse. So you have to do screening, whatever to alcohol or to the drug. So to the drug, it's called DAST, drug abuse screening test. To the alcohol, it's called CAGE questions or Paddington alcohol test or audit questions. So you have 4 screening, very common screening tests. For drug, so these questions, it's unlikely to ask you in the exam about this question, but just be familiar with that. Have you used the drugs other than those required for medical reasons? Means illicit drugs. Which recreational drugs, if you said yes, which recreational drugs have you used in the past year? and give him examples, methamphetamine, cocaine, heroin, ecstasy, or anything else. How often have you used these drugs? Monthly, weekly, daily, and where? Do you abuse more than one drug at a time? Is it with alcohol? Why do you use them? Are you unable to stop using drugs when you want to? Have you ever had blackouts or flashbacks as a result of drug use? Do you ever feel bad or guilty about your drug use? Do your spouse or parents ever complain about your involvement with drugs? Have you neglected your family because of your use of drugs? Have you engaged in illegal activities in order to obtain drugs? Do you feel withdrawal symptoms, like feel sick when you stop taking the drugs? Have you had medical problems as a result of your drug use? So it will help you in real practice and it will help you in OSCE exam. Okay. Do you inject drugs? Have you ever been in treatment for a drug problem? So this is called screening and called examination as well. According to this screening, you will understand the patient has dependence or not on the drug. Okay, according to the answers. What about alcohol? So alcohol, you can ask the patient whatever cage and dependent together. Otherwise, you can ask about audit C question. C. So cage questions. Have you ever felt that you should cut down on your drinking? So C for cut down. Do you get angry if people mention your drinking? So A for angry. Do you ever feel guilty? G, guilty about the amount you drink. Have you ever had a drink first thing in the morning to settle your nerves? So it's called eye opener. Once he will open his eyes, he will drink. So E, eye opener. And ask him about Paddington, alcohol test. How often do you drink alcohol? Monthly, weekly, or daily? What is the most you will drink in any one day in units? So we'll say, for example, 3 units. And also you can ask about the name. Do you feel your attendance in ED is related to alcohol? Yes. So any yes here, it means the patient is dependent. Any yes in cage, any yes in Paddington, the patient is dependent. Okay. Audit question, same. So no need to waste the time here. The clinical institute withdrawal assessment for alcohol scale. So it's called the SIWA scale. So if you find the patient in the scenario has nausea, vomiting, tremor, paroxysmal sweat, anxiety, agitation, tactile disturbance, auditory disturbance, visual disturbance, headache, fullness in the head, orientation, clouding of sensorium. So SIWA scale, if you find these points less than 5, it's mild alcohol withdrawal. If you find 16 to 20, so moderate alcohol withdrawal. If you find more than 20, so severe alcohol withdrawal. You have some scores, it's unlikely to ask you in the exam, but be familiar with them. So T is screen for alcohol abuse in pregnant. This one specific for pregnant. Schizophrenia test and early psychosis indicator. So this one for schizophrenia and psychosis. Edinburgh postnatal depression scale. So this one for patient, she has depression and she has PERS. She has depression after PERS. SCOFF questionnaire, so screening tool for eating disorder. The patient has eating disorder, so you will use this scale or this score to screen for eating disorder. So this for audit C. Okay, so again, if you have alcohol or substance, what you will do, SPIRT. SPIRT here, it means S, screening, B, brief intervention, PI, R, refer to treatment. So first of all, with any patient with alcohol in ER or substance misuse, if you will work in the UK, so screen the patient. Whatever alcohol, you will ask about cage and the bat. Otherwise, you will ask about ODC questionnaire. Substance misuse, so you will ask for dust, questions of dust. After that, you understand this patient, he has dependence or not. So brief intervention here, you will raise the subject, provide feedback, enhance motivation, develop a plan, and refer to treatment, whatever alcohol and drug specialist for counseling. So raise the subject here, it means you will explain your role, ask permission to discuss alcohol drug use screening form. So take consent from him to ask him these questions. Ask about alcohol drug use pattern. Listen carefully. Provide feedback. So here, inform him according your data. You have high risk or low risk or moderate risk. Inform him honestly. Enhance motivation. So explain to him what is the risk, what is the benefit of these drugs, or what is the risk and the benefit of this alcohol. So he will understand, and you can persuade him from these points. Okay. After that, negotiate. So inform him. Did you try to stop? Did you try to decrease? If yes or no, or whatever. Would you like to stop? Would you like to decrease? Would you like any help? We are here to support you. We are here to help you. Would you like if I make a point for you for drug and alcohol specialist for counseling? No one will force you. It will help you to decrease or stop. Okay. So this is how to manage alcohol and substance abuse. It's called brief intervention. So what are the conditions related to this presentation? So Wernicke's encephalopathy associated with alcohol abuse. So already you make screening and you find the patient has alcohol dependence. So you have to exclude Wernicke's encephalopathy also and other cause of thiamine deficiency. So check the triad in the scenario. If you find acute confusion, ophthalmoplegia, ataxia, AOA, acute confusion, ophthalmoplegia, ataxia. So it means Wernicke's encephalopathy. Choose in the options. Other possible features include papilloedema, hearing loss, apathia, dysphagia, memory impairment, hypothermia. Peripheral neuropathy usually confined to the legs also occurs in most cases. The condition is characterized by acute capillary hemorrhage, neural death in the upper brainstem. This can be seen on MRI scanning, but CT scanning appears very little diagnostic value. What about patients untreated? They can develop Korsakoff psychosis. So features of that: retrograde amnesia, inability to memorize new information, disordered time appreciation, confabulation. So maybe you will find a mix between two syndromes, Wernicke-Korsakoff syndrome. So the patient has ophthalmoplegia, altered mental state, gait disturbance, ataxia. Delirium tremens, so the patient has delirium, sudden confusion, autonomic activation and agitation brought on by acute detoxification from alcohol. It can progress to seizures and heart arrhythmia. It can affect brain, heart. Treatment, so give the patient benzodiazepine, such as chlordiazepoxide. Remember that. Indication for admission for patient with acute alcohol withdrawal. Which patient you will discharge, which patient you will admit. So any patient with risk of developing withdrawal seizures or delirium tremens, admission. young people under 16 years who are in acute alcohol withdrawal admission, vulnerable people who are in acute alcohol, so frail or they have cognitive impairment, multiple comorbidities, lack social support, or learning difficulties. So these are indications for admission. If you find any of them in the scenario, so choose admission. NICE currently recommends the use of the following formal assessment tools to assess the nature and severity of alcohol misuse. So audits, as we mentioned, okay, SAD and LDQ for severity of dependence, clinical, so C1, okay, alcohol use disorder identification test audit. This simple screening tool to pick up the early signs of hazards and harmful drinking and identify mild dependence. More detailed than Gage questionnaire and is currently recommended by NICE for the identification of alcohol misuse. Management of vernix encephalopathy. So you can give parenteral, and prophylactic. So this one short term and this one long term management. So patient with suspected vernix encephalopathy who are malnourished or at risk of malnourish. So you can give IV thiamine and then oral thiamine. Decompensated liver disease or who are attending hospital for acute treatment. What about prophylactic? So harmful or dependent drinkers if they are in acute withdrawal or before and during assisted alcohol withdrawal. Parenteral thiamine is available as part of vitamin B substance with ascorbic acid preparation. Pabrinex contains the following vitamins. So thiamine, vitamin B1, riboflavin, vitamin B2, pyridoxine, vitamin B6, nicotinamide, vitamin B3, ascorbic acid, vitamin C. What about benzodiazepine? So management of alcohol-related withdrawal symptoms. At present, only diazepam and chlordiazepoxide have UK marketing authorization for the management of acute alcohol withdrawal symptoms. Clomiciazole has UK marketing authorization for treatment of alcohol withdrawal symptoms where close hospital supervision is also provided. So he went to use that under monitoring. So caution in prescribing for individual known to be addiction prone and to outpatient alcoholics. Also advise against prescribing to patients who continue to drink or abuse alcohol. Alcohol combined with clomiciazole, particularly in alcoholics with cirrhosis, can lead to fatal respiratory depression. So don't use with any patient with cirrhosis. Other benzodiazepines like alprazolam, clobazam, lorazepam, at present don't have UK marketing authorization. So don't use these drugs if you find the options. Other benzodiazepines, 3 drugs, if you find in the scenario, don't choose. Choose benzodiazepine in any case. Otherwise, if under monitoring and no contraindication, you can use clomiciazole. What about carbamazepine? Used in the UK clinical practice in management of alcohol-related withdrawal symptoms, but doesn't at present have UK marketing authorization also. So again, use only 2 drugs. So it will be diazepam only and chlordiazepoxide and clomiciazole under monitoring and no contraindication. Exploring the reason behind previous relapses, explore the patient beliefs and understanding of the condition. Refer to the community drug and alcohol team. So these are points of the management. May be a good idea at some point. outpatient or community detox. So these programs to help the patient to stop or decrease the amount. If the patient drinking has been sustained and heavy for many years, they may end up requiring admission. Suddenly, abstaining or prescribing chlordiazepoxide could be potentially dangerous because the patient will stop, can cause withdrawal symptoms. So suddenly detox may cause delirium tremens. So if you will do detoxification of the patient, take care should be under monitoring, which can have catastrophic effects. Chlordiazepoxide used in experienced hands, close monitoring with regular GP or specialist appointment. Liver function could be part of general workup, but is unlikely to be needed for leg laceration. IV fluids and the nutritional advice are not addressing the longer-term issues. So you can give the patient in short-term management, IV fluids and nutritional advice, but here it's not for long-term issues. Suggesting that the patient stops drinking immediately may be dangerous. Asking a relative to monitor a patient is not safe or suitable. So don't say, we will treat the patient now and go with his relative, he will take care of him. No, this patient needs monitoring. Okay, Camprosat or Campral, this medication used as part of treatment of alcohol dependence, stabilizing chemical signaling pathway in the brain that is disrupted by alcohol withdrawal. So this one works best when used in combination with psychosocial support. The usual dose is 1,998 milligram. So you can give 666 milligrams 3 times a day, unless the patient weighs less than 60 kilogram. And then maximum of 1,332 should be prescribed per day. Prescribed for up to 6 months or longer for those benefiting from the drug who want to continue with it. Be stopped if drinking persists 4 to 6 weeks after starting the drug. Patient prescribed Acamprostat should stay under supervision at least monthly for 6 months and at reduced but regular interval if the drug is continued after 6 months. There is no requirement to perform regular routine blood tests, but they can be considered if monitoring for recovery of liver function is required. Okay, condition number 2, depression. So as we said before, you can use Diagnostic and Statistical Manual of Mental Disorder 5th edition, DSM-5. So American Psychiatric Associations. The definition is 5 out of 9 defining symptoms for at least 2 weeks. So this is how to diagnose depression. You will find 5 out of 9 symptoms of depression for at least 2 weeks. If the patient has these symptoms only today, it's not depression. 1 week, it's not depression. So should be at least 2 weeks. So what are these symptoms? Persistently low mood, loss of pleasure or interest, disturbed sleep, decreased or increased appetite, and or weight. So it's not about decreased or increased appetite and or weight. Fatigue, loss of energy, agitation or slowing of movements, poor concentration, feeling of worthlessness or excessive or inappropriate guilt, suicidal thought or acts. So if you find 5 of 9 and 2 weeks, that's a depression. Organic causes of depression. You have to exclude hypercalcemia. Any patient with persistent sadness, check hypercalcemia, commonly associated with depression, but not hypocalcemia. So hypercalcemia can cause depression, hypocalcemia not. Hypothyroidism and perimenopause associated with depression. It can be questioned. Each point, when you are studying any guidelines, each point can be a scenario. Hypothyroidism and perimenopause associated with depression. Chronic disease states such as Parkinson's disease, COPD, have a strong association with depression. Steroids have association with both psychosis and depression. In a patient using steroids, you can expect at any time you will get psychosis or depression. Temporal arteritis associated with acute psychosis but not depression. So if you find in the scenario the patient has temporal arteritis and ask you which of the following condition you can expect, so psychosis, not depression. Hyperkalemia, it's not associated with depression. So hypercalcemia only. Thiamine deficiency is not associated with acute confusional states, but not depression. Thiamine deficiency with acute confusional states, but not depression. The clinical feature of depression, as we said, these symptoms: loss of reactivity as opposed to increased reactivity characteristic of depression. So if you find in the scenario depression, if they ask you loss of reactivity or increased reactivity, no, it's a loss of reactivity. Condition number 3, eating disorders. So bulimia nervosa as opposed to anorexia nervosa. Most patients with bulimia nervosa have normal body mass index. So the difference between anorexia nervosa and bulimia nervosa, body mass index. The clinical features of bulimia nervosa, so episodes of binge eating, urging vomiting after binge episodes, preoccupation with weight and the body image, preoccupation with eating, periods of starvation, abuse of diuretics, laxatives, and thyroid hormone. So you will find the patient always using diuretics, always using laxatives, always using thyroid hormones to affect his body weight. Often patients have callosis over their knuckles caused by scraping against their teeth whilst inducing vomiting. So the patient is inducing vomiting for himself. He wants to vomit, even he doesn't have any symptoms of vomiting. He is inducing vomiting for himself. Repeated vomiting episodes can also cause erosion of dental enamel because of repeated vomiting. There's a strong association between bulimia nervosa and the depression and the deliberate self-harm. Condition number 4, personality disorders. The clinical features: borderline personality disorder. So you find in the scenario unstable relationship. So if you find in the scenario unstable relationship, think about personality disorder. Undue anger, variable moods, chronic boredom, doubts about personal IT, intolerance of being left alone, self-injury, impulsive behavior that is damaging to the person. So think about personality disorder. Condition number 5, acute psychosis, including bipolar or schizophrenia. Be familiar with these terms. So clang association, logorrhea, word salad. From the name word salad, it's like salad. The patient is telling, mixing words. Clang association, grouping of words usually rhyming words based on similar sounding sounds, even though the words themselves don't have any logical reason to be grouped together. Clang association are seen in patients with schizophrenia and bipolar disorder. So if they mention in the scenario clang association, after assessing the patient, he has clang association. So think about schizophrenia and bipolar disorder. Or they can ask you by different way, the patient has schizophrenia, which of the following you can expect clang association. Logorrhea, type of communication disorder that cause excessive wordiness, and repetitiveness. This can lead to communication difficulties, incoherency. It can occur in patients with frontal lobe disorder and the thalamic region. Word salad is confused, unintelligible mixture of seemingly random words and phrases. So the patient is using words like salad. This you will find in schizophrenia and dementia. The incidence of schizophrenia is equal in all social classes. So it's not related to any class. Schizophrenia can affect any patient. The lifetime risk of schizophrenia is 1%, and the prevalence is equal in men and women, same. The average age of onset is between 15-45 years. Men tend to present younger than women, so it can happen in men in young age. Recognize the genetic predisposition for schizophrenia. So it's a genetic predisposition. The risk of first-degree relatives also being affected is 10%. The risk of children being affected 40%. Concordance is monozygotic twins is around 50%. Sadly, approximately 10% of patients suffering from schizophrenia go on to commit suicide, especially in the early stages. So 10% can suicide. Acute psychosis, including bipolar schizophrenia. So how to understand this patient has poor prognosis or good prognosis? The patient diagnosed already, whatever bipolar disorder or schizophrenia, how to understand from the scenario, or they can ask you, what is the prognosis in this condition? So if you find insidious onset, it's poor prognosis. Acute onset, it's a good prognosis. No identifiable precipitating event, it's a poor prognosis. You find precipitating stressful event, the patient lost his work or lost his loved one or, so it's a good prognosis. So family history of schizophrenia, poor prognosis, young age of onset, poor prognosis, history of previous episodes, poor prognosis, low intelligence, poor prognosis, absence of affective symptoms, loss of emotion, delayed treatment, the patient discovered late, so it's a bad prognosis. Here in good prognosis, again, acute onset, precipitating stressful event, so it's a good prognosis. No family history of schizophrenia, so good prognosis. Family history of depression, it's a good prognosis. Older age of onset, so he has schizophrenia or bipolar disorder in old age, it's a good prognosis. No history of previous episodes. Normal intelligence. No loss of emotion and prompt treatment. The first rank symptoms of schizophrenia described by Kurt Nieder are auditory hallucination, passivity phenomena, delusions. So if you find in the scenario the patient has auditory hallucination, it means acute psychosis, and think about bipolar or schizophrenia. So third person voices discussing the patient. You are talking with the patient and the patient hearing third person. Okay, third person voices discussing the patient. Thought echo, sometimes thought interrupting, whatever, stealing, botting, interrupting, spying, so it's called thought echo. Passivity phenomena, so thought insertion, withdrawal, broadcast, feeling of thoughts and actions being under external control. Delusions may be primary or secondary. Chronic schizophrenia is characterized by negative symptoms, which include poor motivation and self-care, social withdrawal, depression, flat-blunted effect, emotional ignorance, decreased activity, poverty of thought and speech. If you find in the scenario loss of inhibitions, pressure of speech, grandiose delusions, so this mania, increased anxiety in social circumstance, this indicates social anxiety disorder. So be familiar with these terms. You can find in options. So thought echo occurs when patient hears their own thoughts as if they are being spoken loud. So he's talking and he's telling you he can hear his voices, his words. So it's thought echo. When there is some delay, these are known as echo disturbance. When heard simultaneously. So what is the name, guys?
Gaden Kindler what?
Geda Kinla 20.
Okay.
Difficult name, والله.
Graphoria, so communication disorder expressed by excessive wordiness with minor or sometimes incoherent rambling, specifically in written work. Essentially, a written version of word salad and can be seen in patients with schizophrenia. Thought blocking, so this one in writing, communication disorder in writing. Here, thought blocking, unpleasant experience of having one's train of thought curtailed absolutely, seen in several psychiatric illness, including schizophrenia, occurs when person's speech suddenly interrupted by silence that may last a few seconds to a minute or longer. Condition number 6, somatic symptom disorders. So recurrent, multiple, unexplained clinical symptoms. So if you find in the scenario, the patient, recurrent attendance, and the multiple symptoms, and unexplained, so think about somatic symptom disorder. The patient is feeling from pain at least 4 different sides. I have headache, I have body pain, I have back pain, I have knee pain, at least 2 gastrointestinal problem, I have stomach nausea, I have vomiting, 1 sexual dysfunction, 1 pseudoneurological symptom. So he had somatic symptom disorder. If you find that in the scenario, you can diagnose somatic symptom disorder. Hypochondriasis, we discussed earlier. So preoccupation about having serious illness, such as cancer. The patient is worried. I am worried about cancer. So it's called hypochondriasis. Munchausen syndrome. So feigning of illness or disease to draw attention and sympathy. So the patient will say, I have blah, 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 blah. So she will get in attention. She wants her husband to take care about her. She's inventing. Okay, so it's called Munchausen syndrome. Stress disorders. So the patient has been exposed an acutely traumatic event in which he is likely to have experienced intense fear and helplessness. Witnessed the death of his spouse in shocking circumstance. So they will mention in the scenario, the patient father died after that she has blah, 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 blah. So think about stress disorder. Common features of acute stress disorder: subjective feeling of detachment and absence of emotional responsiveness, reduction in awareness of surroundings, derealization and depersonalization, dissociative amnesia, flashbacks and dreams about the event. So, for example, she saw her father in accident and she is remembering these events. Symptoms of anxiety or increased arousal. The condition usually lasts between 2 days and 4 weeks after the traumatic event. So they will mention this happened 2 weeks ago or maybe 2 days ago, something like that. Occur within 4 weeks of the traumatic event. Post-traumatic stress disorder. So eye movement, desensitization, eye movement, desensitization, and repressing, trauma-focused are the two main treatment recommendation. So you will find that in the scenario. Suicide. So the highest risk for suicide are previous episode of self-harm. Suicide here is serious form of self-harm. Self-harm may be the patient want to harm herself or others, but it doesn't mean suicide. So suicide, it's serious event of self-harm. Previous episode of self-harm will be 5. Previous mental illness will be 4. Male sex 3. Severe depression 2. Misuse of drugs and alcohol 2. Combination of risk factors are more important than individual factors alone. Also, hospital admission is supposed to create a safe environment. The risk of suicide while inpatient remains high. Even if you will admit this patient to protect from suicide, sometimes they are doing suicidal at the hospital in admission. The risk is also high in the first few months following discharge from hospital. So after you feel the patient is okay and discharge, they will suicide in the first few months after discharge. Protective factors that make suicide less likely include independent children, family members who would be distressed, and religious belief. So regarding suicide, as we discussed, suicide and self-harm, you can use also modified set person score. Okay, according to NICE guidelines for short-term management of violent and aggressive patients, which of the following should be used first line of rapid tranquilization of this patient?
Lorazepam.
Okay, why?
Benzodiazepines.
Benzodiazepines is the first drug of
First line.
choice.
Yes,
We should not taking medication.
why
Patient
lorazepam?
has refused oral medication, and there is no history of cardiac history or anything in this scenario. So we use first line treatment, lorazepam alone.
Yes, here he said 24 years, brought by police, strange behavior. So we are talking about aggressive and disturbed behavior. Brought in under section, which is section here, guys?
136.
Section 136.
Yeah, is known to suffer from schizophrenia. So what does it mean, suffer from schizophrenia? He's using antipsychotic drugs. It means he's using antipsychotic drugs. Okay, he's known to suffer from schizophrenia, but his friend states that hasn't been taking his medication recently. He became agitated, violent, aggressive, being approached by police and now handcuffed, saying that he hears the voices, so he has auditory hallucination because of schizophrenia, psychosis. So what you will use, lorazepam or haloperidol?
Lorazepam.
We don't have here haloperidol and
Haloperidol, yes.
the bromethazine. We don't have haloperidol and bromethazine. Okay. When assessing this patient, which of the following features should your examination room have?
An internal inspection window.
Number 3.
Number 3.
Excellent. So internal inspection window for safety. Which one of the following factors has been shown to increase the risk of violence?
Coercive, first option. Coercive behavior.
Coercive behavior.
Okay, coercive behavior. According to NICE guidelines for short-term management, violent and aggressive patient.
Lorazepam.
Already taking haloperidol and promethazine, so we'll use the next step lorazepam.
Okay, he said here, no response. No response to haloperidol. What if he has partial response? Which answer?
You
will
repeat
repeat the same.
haloperidol.
It will
I
be
am haloperidol
Repeat
and
after
I am
15 minutes.
repeat. Okay. Which of the following factors has not been shown to increase the risk of violence?
Alcohol intox. No.
Anxiety disorder.
Low level.
Option 2.
Low levels of self-care.
Low levels of self-care.
Anxiety disorders.
Alcohol intoxication.
Anxiety disorder.
Anxiety disorder.
Okay, anxiety disorder. Why? Okay, so alcohol, it can increase the risk. Male, low level of self-care, previous violent episodes. Short-term management of violence. So he has here history of heart disease and
Lorazepam.
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 yeah, because of heart disease.
History of heart disease, yes.
Short-term management, restraint and
Lorazepam.
required tranquilization.
Lorazepam.
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 Okay.
Haloperidol and promethazine.
Yeah. Option 2.
Second, option 2.
Okay, so he became agitated, violent, aggressive after being approached by the police, saying that he heard voices, he's refusing oral medication. So why here haloperidol plus promethazine?
Known schizophrenia. And, there is no option for lorazepam alone.
Yes, no option for lorazepam. Okay. Following is most suitable to achieve rapid tranquilization.
Second.
Option?
Option B.
I am lorazepam.
I'm lorazepam alone.
Option 2.
Okay. What is the best next management step in dealing with this situation?
Last option.
Yeah, last option. Redirecting the patient towards a calmer person.
Yes. Redirecting the patient towards a calmer personal space. So to not make him more aggressive. Single most likely diagnosis. He's very worried about variety of symptoms he's
Generalized
experiencing.
anxiety disorder. Option 3.
Panic is unusual and constantly worries about his health, suffering from headache, difficulty swallowing. It's specific. Very concerned might indicate a serious underlying condition. Doesn't have occasional panic
See,
attacks.
generalized anxiety disorder.
Generalized anxiety.
Yes, sir.
Okay. Single most likely diagnosis.
Dry mouth.
Anxiety, dry mouth.
Cannabis use.
Cannabis.
Okay. Which type of acid-base disorder would you expect to be caused by hyperventilation? Second to anxiety.
Respiratory alkalosis.
Okay. Single most likely diagnosis.
Meadows syndrome.
Okay. So mother bring 2 years old son, previously presented 10 times over past 6 months. Previously investigated for multiple episodes of rectal bleeding. No cause found. So it's Meadows syndrome. Not a risk factor for self-harm.
Number 1, living with large extended family.
Yes. Sad person score. If you find a question like that in the exam, so you can skip, flag, choose any answer, flag, and then you can come back to this question in the end. So anyway, you can. Yeah, second. Which section Mental Health Act gives the police this power?
136.
136.
What does Section 2 for Mental Health Act allow?
First one, 28 days.
28 days.
Excellent. Which section would be used for this patient in this situation? You discuss the patient with senior colleague who suggests that the patient may need admitted under section of mental health for assessment. For assessment.
Section 3. B.
Assessment.
3.
Oh, assessment 2.
Section 2.
2.
Yeah, he did not say treatment.
Treatment is.
Yeah. All right.
Section 4.
72 hours.
Okay, so we have 4 will be 72 hours because section 2 will be delayed. Not important when assessing capacity.
Option 2.
Option 2 must not be under influence of.
Okay, so maybe the patient is using drugs or alcohol, but he has capacity, right? Regarding consent, which of the following doesn't have to be true for consent to be valid? Not. Option?
3.
4.
4.
4.
Consent must be explicit or the person actively agreed verbally or in writing. Okay, so section 5.
Option 4.
Okay, so emergency holding power for admitted patient to provide temporary restraint while waiting assessment by psychiatrist. Not a key principle of Mental Capacity Act 2005. You have 5 principles.
Capacity must be proven.
First choice.
Okay. Section 3 of Mental Health Act.
Months. Option 2.
6 months.
Yeah, 6 months for treatment.
Yeah, treatment. Not an indication for admission for this patient. He's talking about inpatient detox. He has
Age and
withdrawal.
A.
Option 1.
Okay. Previous successful inpatient detox.
Mm.
So he has cognition impairment, you can admit. Multiple comorbidities, okay. Under 16, okay. Risk of developing withdrawal seizures, okay. Oh, this one answered already. Which of the following tools can be used to screen for alcohol misuse? Underlying cause for this condition?
Thiamine deficiency. Option 2.
Okay, excellent. What would be the most appropriate action to take?
Option 4.
First one.
First one, excellent. So explore the reason behind her previous relapses and the methods she has used to stop drinking in the past. Which type of acid-base disorder would you expect to be present?
High annual gap. Raised annual gap. Option 3.
Yeah, raise the HAGMA. Should you do? When this doesn't happen straight away, she begins to shout and threaten some of the other patients in the waiting area.
Option 2. Okay.
Security.
Security.
So here, patient comes to ER, known to be alcoholic. In the reception area, she becomes aggressive, starts demanding to be seen immediately. When this doesn't happen straight away, she begins to shout and threaten some of the other patients in the waiting area. So we will take one by one, ask one of the nurses to give the patient some sedation, inform alcoholic patient that her behavior is unacceptable, and she will be asked to leave the department. So not option. Call the police, ask the reception staff to come and deal with the patient. So first of all, call security. Which of the following vitamins is contained in Paprenex?
Option C. Vitamin C.
Yeah.
Vitamin C.
Okay. Which other drug will you administer to him whilst he is in emergency department? So this patient, alcohol misuse, he's talking about usual drink of. You administer dose of chloride disoxide to ease his symptoms. IV Paprenex. Okay. Which of the following is an indication for admission?
A.
Option 3.
A.
Learning difficulties.
Learning difficulties. Which of the following classically seen as part of Korsakoff?
Antegrade amnesia.
No, it's retrograde amnesia. So disordered time.
Okay. Most appropriate action to take? Alcoholic, 15 to 20 units per day, it's too much. This 3 p.m. already appear intoxicated, refusing to be assessed and wants to go home. What do you think?
Community drug and alcohol team. 4.
Number 4.
Okay, suggest a referral to community drug and alcohol team. What is the best course of action for you to take? She appeared intoxicated on admission. Decision was to observe her overnight. Fully alert oriented, it means cognition done. Very apologetic about her behavior. She doesn't want to wait to be reviewed by the doctor. Excellent. Refer the patient for follow-up in the community by alcohol outreach team. This one answered already.
What did you
Okay.
say?
Which of the following is an indication for admission for this patient?
16.
16.
Under 16.
Yes, under 16. Classically seen on Korsakoff.
Confabulation.
Excellent. Following screening test recommended by current NICE guidance.
Cage.
Okay. Which of the following vitamin is not contained?
Vitamin C.
B12.
Last
B12.
B12.
Okay.
B12, sorry.
Following symptom is classically seen as
Red
part of
coat, red
Korsakoff.
ammunition.
Okay. Which substance is he most likely to be withdrawing from?
Alcohol.
Okay. Which of the following benzodiazepine drugs? All benzodiazepine. So
Diazepam.
which one?
Last option. Diazepam.
Lorazepam.
Diazepam. Diazepam. Which one of the following benzodiazepine? Current.
Chlordioxyperoxide. First option.
Okay. Which of the following is non-benzodiazepine drugs that is
Carbamazepam.
used?
Option 2.
Okay. What is the single most appropriate management?
Cage 2.
Yes, case 2. Okay. Following a single most likely diagnosis.
Wernicke's encephalopathy.
Korsakoff. So he said here explains that his memory is not too good due to recent professional boxing. Relatives report he drink heavily. He gives a bizarre explanation to some other questions. Which of the following drug will you give to ease her symptoms?
Diazepam.
Diazepam. Non-benzodiazepine.
Clomethazole.
Option first.
A scale should be used to guide the treatment.
SIVA scale.
Okay. Which one of the following drugs will you give to ease her symptoms?
Chlordioxyperoxide. Option 3.
Excellent. Most important management step for this patient?
يلا يا أبو.
IV lorazepam.
Yamin. On examination, you note the patient is underweight. He has uncoordinated gait and nystagmus. So what does it mean? And he's talking about
Ataxia.
examination unremarkable. CT hit is performed, which is non-specific. Which diagnosis is most consistent with this patient presentation? Visual hallucination.
Acute schizophrenia? No.
Alcohol withdrawal.
Alcohol withdrawal.
Yes, alcohol withdrawal. Altered mental state. Which of the following is criterion for diagnosis of Wernicke's encephalopathy?
Kilomotor abnormalities.
Okay.
Ophthalmology.
What is the cause?
Thiamine deficiency.
Thiamine deficiency.
Option 4.
Excellent. Tremulous and
Delirium
diaphoretic.
Delirium tremens.
Delirium tremens.
Okay. Not consistent with depression.
Increased reactivity.
Okay. should be decreased.
Decreased.
Not typical feature of depression.
Increase burst of
Increased burst of energy.
Okay. Single most likely diagnosis.
Depression. Depression.
Okay. One of the following feature is not consistent with diagnosis of depression.
Early morning waking. Depressive behavior.
Which one of the following is potential organic cause of depression?
Hypercalcemia.
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 Yeah,
Last option.
yeah. Most likely diagnosis.
Bulimia nervosa.
Okay. Single most likely diagnosis.
Personality disorder.
Second option.
Variable.
Borderline personality.
Yeah.
Okay. Following thought disorder is he displaying?
Clang association. Option 4.
Okay. Following good prognostic factor in schizophrenia.
Family history of depression. Last option.
Okay. True regarding schizophrenia.
First option.
Excellent. Following what support the diagnosis of schizophrenia.
Grandiose delusion.
Option.
Grandiose. Second option.
Emotional incongruity. Which one of the following is recognized as being a negative symptom of schizophrenia?
Blunted effect.
Okay. Thought disorder is displaying sensation.
Thought echo. Option 2.
Broadcast. He feels that other people can hear what he is thinking.
Stop
So
broadcasting,
broadcasting, spying, spying. One of the following is recognized as being first rank symptom of schizophrenia.
Thought echo.
Thought echo. Thought disorder displaying. He keeps repeating words and statements.
Word
Everything
salad. Second
seems
option.
excessively word.
Logorrhea.
Logorrhea. Which one of the following is a good prognostic factor for schizophrenia?
Good precipitation B.
Acute precipitating.
Okay. Thought disorder displaying. Difficult to understand what is saying.
Thought block.
Word salad.
Word salad. Okay. Disorder he displaying.
Thought echo.
Thought echo.
Thought echo.
Okay. So the following thought disorder he is displaying.
Glaphoria.
Last option.
Last option.
Yes. Following thought disorder displaying.
Thought block. Option 2.
Thought blocking.
Block. Because he said suddenly interrupted by silence. It means he has block. Single most likely diagnosis. Option?
Somatic symptom disorder,
Yes. Why?
because more than 50 times. Complain the same thing.
50 times
Yeah,
over the
50
past
times.
5 years with various complaints. Okay. Single most likely diagnosis.
Post-traumatic
Post-traumatic stress
stress
disorder.
disorder.
Okay.
Stress.
So here,
Oh,
mark a symptom of anxiety, inability to recall the events of the accident. She says that she feels in a daze and quite disoriented and emotional about the event at this stage. Single most likely diagnosis.
traumatic.
Post-traumatic stress.
Post-traumatic stress.
Okay. Single most appropriate treatment.
Eye movement desensitization and reprocessing. Option 3.
Okay. Which of the following factors in his history associated with the highest risk of suicide?
No.
Previous episode of self-harm.
Severe depression. Option 3.
Highest risk of suicide. He's talking about suicide, not self-harm. So previous episode of self-harm. One of the following is true regarding risk assessment tool.
Last option.
History of divorce indicate increased risk. Thank you, guys. Inshallah tomorrow. Yeah, inshallah tomorrow 1 to 3. Okay. Every day we will take one chapter for one session. Thank you, guys. Bye.
Thank you, Dr. Hani.
Thank you, Dr. Hani.
Okay,
Thank you.
thank
you,
you.
Dr. Hani.
Yeah.